Welcome back to Stat Nurse. In today's video, we're breaking down the most common emergency room cardiac drugs you'll see in real life. These medications save lives during cardiac arrest, arrhythmias, and hypertensive crises. Stick around, because by the end of this video, you'll know what each drug does, how it's given, and why it matters in critical care. Epinephrine. Epinephrine is the king of code situations. In cardiac arrest, it's given as 1 mg V push every 3 to 5 minutes during CPR. It stimulates alpha and beta receptors, increasing heart rate, contractility, and systemic vascular resistance. In plain words, it squeezes the vessels, raises blood pressure, and gets blood to the heart and brain. It's not mixed during cardiac arrest, just IV push or intraosseous, but in anaphylaxis, you'll see it as an IM injection in the thigh, usually via an EpiPen. Side effects: tachycardia, hypertension, and arrhythmias. Bottom line, Epi keeps the heart alive when nothing else will. Amiodarone. Amiodarone is the go-to antiarrhythmic in cardiac arrest when shockable rhythms don't respond to defibrillation. The typical dose is 300 mg IV push, followed by an optional 150 mg. It works by prolonging repolarization, essentially slowing down the heart's electrical system. Nurses often see it in ventricular tachycardia, ventricular fibrillation, and sometimes atrial fibrillation. One thing to remember, it has a really long half-life, so side effects can linger, like hypotension, pulmonary toxicity, and thyroid issues.
In a code, though, none of that matters. It's about stopping lethal arrhythmias.
Atropine. Atropine is used in symptomatic bradycardia, when the heart rate is dangerously low and the patient is dizzy, hypotensive, or even syncopal. The standard dose is 0.5 mg IV push every 3 to 5 minutes, up to a max of 3 mg. It blocks the parasympathetic nervous system, letting the heart speed up. If atropine fails, that's when we start thinking about pacing or dopamine epinephrine infusions. Side effects can include dry mouth, urinary retention, and blurred vision. But in emergencies, the focus is simply raising that heart rate fast. Adenosine. Adenosine is the drug that literally stops the heart for a second. It's used for paroxysmal supraventricular tachycardia, PSVT. The first dose is 6 mg rapid IV push followed immediately by a flush. If that doesn't work, you try 12 mg. Because its half-life is only about 10 seconds, it has to be pushed fast through a large vein with a flush behind it. What patients feel? Chest pressure, shortness of breath, or even a sense of doom. It's scary, but usually effective at resetting the heart rhythm. Tantura. Nitroglycerin. Nitroglycerin is used for chest pain and acute coronary syndrome. It works by dilating veins and arteries, reducing preload and myocardial oxygen demand. In the ER, it can be given as sublingual tablets or sprays, IV infusion, or topical paste. Classic order: 0.4 mg sublingual every 5 minutes up to 3 doses. IV infusion is titrated based on chest pain and blood pressure. Key nursing point: never give it if the patient took PDE5 inhibitors like Viagra within 24-48 hours, since it can cause life-threatening hypotension. Side effects: headache, flushing, and low BP. 6. Dopamine. Dopamine is a vasopressor and inotrope often used in shock and severe bradycardia. Dose-dependent effects make it unique. At low doses, it dilates renal arteries. At moderate doses, it increases contractility and heart rate. At high doses, it causes vasoconstriction to raise BP. In the ER, it's given as a continuous IV infusion, titrated to blood pressure and perfusion. Nurses must monitor carefully for arrhythmias, tachycardia, and extravasation injury. Dopamine is less popular now compared to norepinephrine, but you'll still see it in certain cardiac emergencies. 7. Norepinephrine. Norepinephrine, or Levophed, is the first-line drug for septic shock and also used in cardiogenic shock. It's a powerful vasoconstrictor, increasing blood pressure and perfusion to vital organs. It's always given as a continuous IV infusion through a central line when possible. Side effects include limb ischemia, arrhythmias, and hypertension if it's over-titrated. Nurses must use an infusion pump and titrate based on blood pressure goals. Remember the saying, "Leave 'em dead, give Levophed." A bit dark humor, but it highlights how strong this drug really is. And these medications can mean the difference between life and death. And knowing them cold is crucial for nurses, med students, and anyone on the code team. If you found this helpful, hit like, subscribe, and stay tuned for more breakdowns on critical care essentials.